So I guess first of all, Kisa Kukit, or hello. My name is Rachel Bach. I am from the Kiskinik First Nation, which is in the southeast corner of British Columbia. So just before I get started, I'd like to acknowledge the traditional territory that we are on and that I'm a guest here. But I have been living, working, and studying in Winnipeg for the past 10 years, so thank you for making it feel so much like home. Moving on, so like I said, or like Claire said, I was in Kenya as well, so I was living with Margaret. We were roommates, so I just wanted to acknowledge the time we spent together, and that's not the best picture of where we lived, but that is the street we'd walk down to get to the main road every day. It was a very nice apartment, though. So I was working with the Population Council, which is an international NGO. It has offices around the world, and I was in the Nairobi office. So I was there with other interns. There was 4 from UCLA. They were MPH interns, and there was 1 from the University of Copenhagen studying global health. So we kind of created a really interesting mishmash of different perspectives. I was working with 1 student on a project. It was a systematic review, so it was out of a partnership with Fistula Care Plus. So they were working with the Population Council to conduct research because they want to, in the future, create interventions to reduce the barriers that women experience when they're trying to attempt care for obstetric fistula. So our project was the groundwork. We were doing a targeted literature review to help identify the barriers. So the principal investigator was Dr. Charlotte Warren. She's based in the United States, so we only met with her via Skype. However, Dr. Ben Bellows was our immediate supervisor, and he was based in Nairobi and has been living there for the past 5 years. And then Zoe was the intern that I was working with. So this is something I wasn't very familiar with going into my internship. So obstetric fistula is a hole that develops between the vagina and the bladder or rectum due to prolonged obstructed labor, and it results in urinary and fecal incontinence. So it persists in many developing countries across Africa and Asia, despite being eradicated in places like Canada. So when women suffer from obstetric fistula, the incontinence will result in a foul smell and can result in ostracization from the community. And many of these women will be abandoned by their spouses or their families, will not be able to work. And this is on top of having suffered from obstructed labor, which usually ends in infant mortality as well. So it's a very serious maternal morbidity that does exist throughout Africa. So there has been work on obstetric fistula, but a lot of the data is primarily on like surgical methods and whatnot. So we were doing a targeted literature review. So we searched the bibliographic databases, the gray literature. We looked through hand searched through various journals, and then we checked network and organization sites to find everything we could on fistula. We also emailed a few experts to get their recommendations. And then our supervisor had gone to a conference and found out that there was some work being done in the French language, and they asked if we could look into that as well. I was kind of a bad Canadian because I didn't know French bilingually, but we managed to search through it a little. It's not the best graphic, but it kind of shows the process that we went through. So from our database search, we identified almost 4,000 articles, and then we added another 30 from the gray literature search. From that, we reviewed the abstracts with a few criteria to narrow it down to see, we got rid of all the ones that were just focused on surgical procedures, for example. And from that, we narrowed it down to 370 for further examination. We put on a stronger list of criteria to narrow it down further, to see if they actually talked about barriers at all, because a lot of them would just talk about, there were some really great articles, like some were interviewing women to find out more about their experience, but it didn't necessarily target barriers. From that, we narrowed it down to 106 journals that we added the 21 from the expanded search, and in the end, we had 110, which is quite a lot. A lot of literature reviews will kind of narrow it down further to get more detailed information, but we liked the broad kind of categories of articles we had, so we narrowed it down. We gave them 5 categories. So there was actually only 2 articles that looked at barriers to accessing fistula care and acknowledged that that's what they were doing. There were 39 articles that identified factors that we perceived to be barriers. For example, there were a few articles that talked about the psychosocial issues that would come up with fistula, and we felt that that could be a barrier to care in itself, so we included those. There were 29 articles that just mentioned barriers briefly somewhere in it. There were 28 sources that were either reviews or needs assessments or annual reports that would talk about fistula. And then there were actually 12 articles that talked about various interventions that were already in place. So we really looked at the problem from a 3 delays model using Thaddeus and Main's paper from 1994. So we looked at 3 phases of delay. So the first delay is the delay in deciding to seek care. So if you don't decide to seek care, that kind of stops it right there. And various things can influence this. So for example, there's psychosocial issues, there's cultural issues, awareness in itself, as well as social. So phase 2 would be identifying and reaching the medical facility. So there were a lot of issues that would affect this as well, primarily financial and transportation issues. Fistula primarily affects women, I guess, in lower SES or socioeconomic status situations anyway. So financial issues definitely come into effect when attempting to access care as well to treat fistula. As well as transportation, rural areas are affected way more than urban areas, and so the roads in the first place. Many times a woman will suffer from obstetric fistula because she wasn't able to access the facility in the first place, and so now after suffering from fistula, a lot of the same issues come into play. And then phase 3 would be receiving adequate and appropriate treatment once having reached the facility. And so in Kenya, there was a lot of, especially rural areas again, facility shortages and then issues with quality of care. One thing that came up a lot, which was interesting, is the surgical camps. So doctors will fly in internationally and host a surgical camp for fistula, but then they're there for maybe a week and then they all leave. And so it doesn't really encourage a really good patient-doctor relationship. So what we concluded from a review was that while barriers to fistula treatment may be easily identified, we definitely identified a lot of barriers. Their alleviation is difficult and require a sustainable intervention that targets several barriers at once. We saw a few studies that would target awareness, for example, but then if you increase awareness and then women want to come in for the procedure, it's an issue because if they don't have the facilities to do it, you just create a really large backlog. So the results that we identified, the current research gaps. There was definitely a lack of scientific studies. So a lot of the studies that we did find didn't necessarily have a control group in them. So it's really hard to really, I guess, analyze what they were trying to say when there's no scientific methods in place. There was a lack of prevalence studies, but we felt this was interesting because it's very expensive to go and do a large prevalent study and then not offer any treatment at the same time. So that kind of relates back to creating awareness but not offering a solution. And then there was a lack of studies that focused on barriers. So it was really exciting to be involved in this project for my placement because we left a report with the Population Council that is up for possible publication, which is exciting as a student. And also they're going to be using it for future projects in the next coming years to develop interventions. I had another opportunity a lot of my work was in the office, but we did get to go to the field for a visit. So we drove out we flew to the coast, and then from the coast we had to get bodas, like motorcycle taxis, into the rural areas where they would conduct interviews to work on a different study. But I really felt that it brought my whole placement full circle because I got to see a lot of those barriers that I had been reading about so much. So to actually see the roads and see the living conditions and see where the health facilities actually were was very interesting and quite eye-opening. And then just being in Kenya was an amazing experience. There was lots of opportunity to do amazing things on the weekends, and there were really great people that we got to meet. Margaret and Stella and I got to meet some of the UCLA interns and the Copenhagen interns and just had a lot of fun. So just to reflect, I definitely even though I was focused on health, I do feel I got to see a little bit of all 4 pillars of development that we talk about in our coursework. It was very exciting to be involved in global health research and to see the role of the Population Council in the bigger world of research and to see some of the challenges that they have as well. Sometimes I felt they're such a big organization. It was very interesting to see all the things they have to go through to get onto the ground and the different relationships that they do, and it's quite complex, but it works very well. I learned a lot about obstetric fistula, which is something I did not know a lot about before. And then there was definitely some interesting parallels between my domestic placement and my international placement. Last year I was on a First Nation in Manitoba looking at health, and this year I was in Kenya looking at health, so it was very interesting. And it was just a very wonderful country. So, asante sana. in Swahili, thank you. And then Taka, Agose, and Miigwech. Taka is from Kootenay territory, where I'm from. Thank you.
Okay, yes, as a librarian, I'm very interested in the extensive literature review that you did and the strategy for it. But I'm curious, were you accessing, you found thousands of articles initially. Were you going in through the University of Winnipeg's website and looking at art journals remotely, or were you accessing academic databases through an institution in Kenya?
So we did all the searches, because we had a list of all the different electronic databases. We did all of them. And then to actually get the articles, we kind of asked our supervisor, so how are we going to get them? And he was, well, since you're both students, I was hoping between your two schools you'd be able to access most of them. And so I could access some of them through ours that the UCLA student couldn't, and then she could get some that I couldn't. And so we just kind of worked it that way. And then there were a few from PubMed that we just couldn't get, so we had to email and ask them to send them to us. But
Okay, good. Thanks very much. It's good to know.